hear me twice. That better? A bit better, yes. Okay, is everybody online able to hear me properly? Yeah, good. So good morning, I'm Anne Hannah. I'm chairing today the Integration Joint Board Performance Audit and Assurance Committee. I do wish we could have come up with a snappier title, but never mind. This is a hybrid meeting, and we'll be here today to look at all these items that are on the agenda. There will be one change to one of the items, but that will be announced later on. First of all, could I have any apologies, please?
We have no apologies, Chair.
Okay, thank you. And any declarations of interest from anyone? No declarations of interest? Okay, we'll move on then to item 3, which is the minute of the meeting of the Performance Audit and Assurance Committee from 7th March 2025. First of all, can we agree that as a correct minute? I see nobody shaking their heads or trying to speak, so we'll agree it as a correct minute. Are there any matters arising? No matters arising. Move on then to item 4, which is the action log. There is only one item on the action log, and that's in hand to be dealt with at the September meeting. So I don't think, has anyone any questions on that? No. We'll move on then to item 5, which is finance. And I understand Anne-Marie is going to speak to this item.
Yeah. So thank you, Chair. So turning to page 15 in our papers is the Internal Audit Internal Control Evaluation Report for 24-25. This provides an overview of governance within the IGB, providing assurance on the system of internal control, governance and risk management. The internal control evaluation is a key component of the Chief Internal Auditor's annual opinion, which will be included in our annual report for 24-25 to be presented to the August meeting of the PAC. There are no specific findings that I want to draw to the attention of the committee today, but note that management considered the various findings within the report and provided appropriate management responses. In terms of the audit work to support our annual report, this is substantially complete and we anticipate issuing the report in the near future to allow it to come back to the PAC in August. So, Chair, that was all I was planning on seeing on the report and happy to take any questions.
Thank you, Anne-Marie. Does anyone have any questions on this report? I see no hands going up, so can we note the report in the context of evaluating the internal control, governance and risk environment? Note the audit recommendations. Note that this will be included in the internal and annual audit report for 24-25. Agreed? I'll take that as agreed then. Thank you. So we will move on now to the unaudited accounts 24-25. I think this is you, Marie.
Thank you, Chair. This report presents the annual unaudited accounts for the IJB. The public notice period for the accounts begins this Monday, the 16th, following today's consideration by the committee. The accounts includes a management commentary of achievements and developments for the year and sets out the overall financial position along with key national indicators. The 24-25 accounts set out an overall deficit of 5.546 million, consisting of a revenue overspend of 5.037 million, along with additional movements on reserves. A final outturn report is next on the agenda and will give further detail in the final revenue position and the reserves position. The final detailed reserves are set out in pages 44 and 45 of the PAC in the accounts document, with a final balance of 15.7 million following the final draw in reserves to cover the overspend position. the majority of which is committed in future years. Contingency and general reserves are held of 2.4 million, which is in line with the requirements set out in the reserves policy of 0.75% of the IJB budget, which is a more favourable position than was projected at Q3. The commentary also sets out the future financial position and the continuing challenges faced, and includes information on the medium-term financial plan. The recommendations for committee are to consider the unaudited accounts, note the public inspection period, and to note that the unaudited accounts will be submitted to Audit Scotland for audit by the statutory deadline. Members should also note that it is anticipated that the audited accounts are likely to be presented in November, a bit later than the normal guidance of September. It's just to provide assurance that this is a similar situation to last year, and which caused no issues whatsoever. I'm happy to take any questions on the report and the annual accounts document. Thank you.
Thank you, Marie. Does anyone have any questions? This is a really important report, not exactly riveting, but it's a very important report. And it's good to know that there's some improvements in the situation, although we'd like to see far more. Does anyone have any questions about the unaudited accounts? I think people were given an opportunity earlier to make comments, so I'm hoping that any questions have been resolved. Okay, and then we have considered the unaudited annual accounts, and thank you for clarifying on the public inspection period. And these will be submitted by the statutory deadline of the 30th of June. So you've got a busy couple of weeks. Okay, we agree?
Agreed.
Thank you. Right, we'll move on then to the final outturn report. And again, that would be you, Marie.
Thank you, Chair. This is the financial outturn report. It's just first to note that the table at 4.1 is not the final version of the table, so it's been circulated to members this morning via email. It doesn't change the overall position. It's a presentational update around the budget and actual figures, around the final accounts figures. So it doesn't change the overall position. It's just that that final table has been circulated to members this morning, but the overall position doesn't change. So this is the final revenue outturn report for 24-25. The final overall overspend on integrated services was 5.037 million. This consisted of an overall overspend for social care of 7.036 million, which is offset by an underspend of 1.999 million on services for health. The set-aside budget for large hospital services also showed an overspend of 6.173 million, which has again been managed by NHS Forth Valley as in previous years. In social care, the main areas of overspend were as follows. External care and support at home overspent by 5.4 million, which is an improved position of 975,000 since the position projected at Q3. The projected position was based on tracking the previous year's trends, and the final position was more favourable due to both continued reviews and resource allocation panels in place as a budgetary control measure. This was offset by an underspend in the in-house service in relation to vacant posts held of 4.3 million. In-house residential services showed a final overspend of 1.5 million, related mainly to the use of more expensive agency staff to cover absence and vacancies. External residential care overspent by 1.9 million. 2-for-1 approach was adopted as part of the budget recovery actions during the year. Housing with care also overspent by 475,000, mainly in relation to staffing challenges and use of agency staff, although this has been reducing over the financial year and has been brought down significantly. The overspends were offset by vacancies throughout services, with the main area of underspend being assessment and care planning. The NHS underspend comprised an underspend of 3.8 million on community health services, mainly related to development funds not utilised in year and vacancies throughout services. These were offset by a year-end overspend of 420,000 in relation to complex care cases. Primary care overspent by 1.8 million, mainly in relation to prescribing pressures, which were highlighted throughout the financial year. The position improved by approximately 200,000 over the final portion of the year. Savings targets which were agreed as part of the budget are set out in Appendix 4. and show an underachievement during the year of 3.125 million on integrated services. The majority of these have been picked up as part of the pressures in the budget paper and medium-term financial plan, which was presented to the IJB in March. The reserves are set out as section 5 and also in detail in appendix 5. The table on page 60 of your pack shows the balances at year end. There was an opening balance of 21.2 million, an in-year deficit as noted per the accounts paper of 5.546 million, and a closing balance of 15.715 million. Of this, 12.7 million is committed for future years, and there remains contingency balances of 2.371 million and 600,000 of service pressure reserves, and that contingency balance is in line with the reserves policy at 0.75% of the overall IJB budget, which is a more favourable position than we anticipated at Q3. The committee are asked to note the position in the final draft outturn, note that the 1.999 general underspend on health has been utilised to offset the overspend on social care, note the use of a further 4.703 from non-recurring reserves to fund the final overspend within social care, note the final non-recurring reserves position and related risks set out in the paper, and note the payment of up to 1 year of funding to Strathcarron Hospice for their hospice at home service. This was a service that was not part of the overall budget agreed, and since then a report has been brought to the senior leadership team, and we're going to take that to the IJB for approval. So we're just asking Audit Committee to note that as well, that the IJB will be presented with that for approval at their meeting. I'm happy to take any questions. Thanks.
Thank you, Marie. Again, congratulations to everybody who's managing to improve the position, albeit perhaps not as much as we would like to improve the position, but I'll take any improvement that's going. Does anyone have any questions? No questions? Okay, we're going to gallop through this meeting. In that case, can I ask that you note to the final draft outturn for the integrated budgets and set aside services, note the 1.999 million underspend that's been utilised to offset the overspend, note the use of the further 4.703 million from the non-recurring reserves to fund the overspend in social care. Note the final non-recurring reserves position and the related risks set out in the paper, and note the payment to Strathcarron Hospice, which will come again to the IJB for agreement. It's not necessary for us to agree it here today. Do we agree these recommendations?
Agreed.
Agreed. Thank you. In that case, we will move on to the annual performance report. And I understand that, Tom, you're going to present this for us.
I'll do the preface if that's okay. Good morning, Chair, and good morning, members. And my colleague Leslie MacArthur is with us, who is the author of the report and will be able to answer any questions that we have available to us. Members will be aware that the Public Bodies Joint Working Act requires there to be an annual performance report available to the IJB, with content particularly expected to be around the core integration indicators as well as the national health and wellbeing outcomes. However, partnerships are also encouraged to report on and expected to report on additional relevant information, as well as that minimum set that I've indicated there, and that includes things like reviews of a strategic plan, assessment of performance in relation to national health and wellbeing outcomes, etc., financial planning, best value, performance relating to locality setup, and inspection of service experiences during that year. I just want to draw attention to a couple of highlights in this year. In relation to the service developments and redesign of the Dollar Park Dementia Service, which relaunched on the 31st of July following a £128,000 investment in its building and staff. Obviously, users and their families are benefiting from the enhanced facilities and expanded opening hours, including new evening and weekend service, which launched in December. The review work stream of care and support for adult service is undertaking 450 reviews, and that's helping to tackle the backlog and resulting in service savings of over £1 million to the partnership. The CSV Falkirk District supported the Health and Social Care Partnership to introduce small grants programme of up to £500 for community-based groups and organisations to mark World Suicide Prevention Day. 7 local third sector groups were successful and supported to deliver community-led events and activities, raising awareness of this vitally important issue in the area. And also, it has been a good year, we believe, in relation to our continued priority about engaging well with our local communities. And during the last year, over 440 people responded to an online survey. We actively promoted these surveys and gathered views from over 900 people across 58 engagement activities. Those range from drop-in sessions at local libraries and planned events to attending local group meetings. The one last thing I would say before we open it up for questions, if that's okay, Chair, is that obviously this happens every year, I believe. The performance information prepared by Public Health Scotland is not available until after this period in July. But the APR will be updated, the National Integration Indicators section, as soon as that's available to us. And happy for particularly Leslie, but myself as well, to take questions.
Thank you, Tom. As those of you who have been at meetings with me often, you'll know that my big interest is the consultation. I've been very impressed by the level of consultation that has been going on over the past year, and I want to commend people for that. Although I would still always say we could do better. Because it really is important that people understand the nature of the service and are able to help shape it. So well done to all on that front. Any questions or comments? Jim, I think.
Yep.
Councillor Flynn.
Yep, thank you. Thank you, Chair. First of all, my apologies if my question doesn't directly relate to the page that I'm referring to. It's really for clarity. It's page 94. And it's priority 2, which refers to ED department, the emergency. Now, I'm assuming this is obviously what I would call A&E, and I'm looking at the direction of travel for 4-hour waits. Now, the first thing I would like to ask, Chair, is that could somebody please clarify when the 4-hour wait starts and when it stops? Is it when the patient obviously registers at reception and then see a triage nurse? Is that then the 4-hour clock? Because I've been in A&E before myself, and other people have, and I've noticed the clock goes up while you're sat there, and then sometimes that's used as an excuse for the longer delay. So that's the first question. Thank you.
Tom, I'm not sure that it's the same page in my papers, but
well, this is what I'm trying to clarify. Yeah,
if
is it the same thing?
My hesitation is about giving a coherent and accurate answer to you, to Councillor Flynn, rather than giving it.
I'm happy, Tom, for you to come back to me with.
If that's okay, Councillor
Yeah,
Flynn.
of course it is.
Okay,
yeah,
because I think I know the answer to it, but I don't really want to try. I don't want to give an answer.
No, that's right.
Can I interrupt for a second? Gail's telling me that she thinks she can answer the question.
Okay.
Yeah.
Yes, so Councillor Flynn, my understanding is the 4-hour access standard is the time from attending at the front door of the hospital until a decision is made around your future needs. So that might be, so it's time for first assessment. So that might be that you get sorted and you go home, or it might be that you are waiting to go into a bed in a ward. So it's a time from attendance arriving until the first assessment.
Okay, so that's quite an ambitious. Yeah, that's quite an ambitious target then, isn't it? Really, because it's an unknown quantity how many people are going to turn up at A&E, and I see it's now a screen. The time moves up and up and up. So when a person registers, their clock starts then. So that's what I'm understanding. Yep. Yes. Yep.
Yeah. Yeah,
Thank you.
Thank you. Yes, Gail's explanation there accords with my understanding of the position as well.
My second question really, it shows the number of people attending. I just wonder, is there any information on the number of people who register, but then because of the long wait or other circumstances, then leave? Because I think that's an important number that we really should have to hand. It's not a criticism, it's just I like to get the facts, because I had a relative recently went in and he was there for, I don't know, 10, 12 hours. I'm no criticism of that. But he did say they saw quite a number of people just wouldn't wait and got up and left.
Gail's saying she can answer that, and I see Callum has his hand up as well.
Yeah, I was just going to come in and say that there's a lot of data around attendance at the front door and next destination, including if people decide to go home before they've been seen. But Callum's probably got more detail on that than myself.
Thank you.
Yes, thanks, Gail, and apologies I've missed the start of the conversation. We recently undertook a bit of a deep dive into the data around the Emergency Department of Public Health Scotland, and we do have some data around that. So what I can do, or what I would propose, is that we can bring some of that and include that into the report for next time round, if that's okay.
Yep, as long as it's okay with the chair and the rest of the group. Yep, thank you, Callum.
That sounds like a reasonable way forward.
Thank you.
So thank you, Callum. Victoria?
Yeah, thank you, Chair. It's just very quickly, just to make sure that the minute is correct. Tom was referring to the Suicide Prevention Fund and mentioned that it was delivered by CSV. It was actually delivered by CVS Falkirk District. CSV is a different organisation, and I know we are a bit of a tongue twister, but it's just to make sure that the minute is correct.
Apologies, Chair. Yeah, that was my inability to read.
Totally understand, but just wanted to clarify it.
Thank you for that correction, Victoria. I'll just keep my favourite drum of I don't like acronyms at all. So
it's been with the organisation for 40 years.
If you say it all.
I'm unlikely to be able to change it overnight.
No,
yeah.
I'm not asking you to do that. It's just my pet hate. Okay, we'll make sure that the minute is correct. Any other questions or comments? I see no other hands. So back to the recommendations. We've considered and commented on the report. Can we endorse the draft annual performance report for submission to the IJB on the 20th of June?
Agreed.
Oh, and we better agree that Callum is going to add in for future reference.
Agreed.
Okay, thank you very much. We'll move on now to the performance monitoring report. And I understand that's you, Callum.
Yes, thank you very much. Thank you, Chair, and good morning, members of the committee. In an effort to streamline reporting, we brought the performance monitoring report together with what was previously separate, the complaints and feedback report. Last time round, we had added that on as an appendix, and we've now integrated it into the report, and that can be found in sections 4 to 8 of the full report. In terms of our regular performance measures, performance is reported up to March 25 and with a year-on-year comparison. The report has a focus on exception reporting, and I'm now going to briefly talk through some of the areas highlighted. The report highlights the position around Emergency Department 4-hour compliance and around delayed discharges. Compliance against the Emergency Department 4-hour access standard was 55.5% for March 25, and that's compared with 45.7% for the same period the year before. There were 74 delayed discharges at the March 25 census, which is a decrease from 81 for the same period last year. The overall position remains under continual review, with sections 3.1 and 3.2 of the main body of the performance report, which I think starts at page 122 of the packs, And there you can find further details as well as some of the actions ongoing to support these areas. There are detailed exception reports for sickness absence across Falkirk Council and NHS services attached to the partnership. For Falkirk Council, absence for the year 24-25 was 10.6%, which is a decrease in performance from the year before when the figure was 9.9%. For NHS services, the overall March 25 sickness absence position is reported as 8.2%, and that's compared with 7.82 in March 24. The report details the latest position for waiting times for psychological therapies, and in March 25, 79.9% of patients started treatment within 18 weeks of referral. That's an increase from the previous month's position of 73.8 and an increase from 72.7 in March 24. Sections 4 to 8 of the full report, which starts at page 132 of the packs, provides the detail of what was previously in the complaints and feedback report and provides information for the period of January to March 25. The report details 33 complaints received via the council complaints handling procedure and 20 complaints via NHS complaints handling procedure during the reporting period. There were no complaints received via the IJB complaints handling procedure. The report highlights complaints received via the council complaints handling procedure have been higher than the year before for 4 quarters in a row now. Also, just to add, there was 15 people took time to provide positive feedback directly to Falkirk Council HSCP services during January to March, and the equivalent figure for NHS services was 12 people providing positive feedback. In terms of recommendations, the board is asked to consider and comment on the content of the report and to note that appropriate actions continue to be taken to address the issues identified. Thank you for listening and happy to take any questions or comments.
Thank you, Callum. I'm glad to see that there are, again, some improvements, but I wonder if you could say a wee bit more about the wait in emergency department, because at 55%, that's still not a very exciting performance. I wonder if you could say a little more about that.
No, I think it has remained stubbornly low since COVID. We're not alone in that. There's other partnerships and boards where a similar pattern has happened, and you know we note there that there has been an increase this round, but actually part of that increase in performance is due to a change in the way that the recording definitions have been changed nationally by Public Health Scotland. So it absolutely remains a real stubborn challenge for us.
So you're saying that the apparent improvement is actually just a change in the recording arrangements?
Partly, not fully. And there is further details in the report of that, but yeah. Yes, a large part of that increase in performance is due to the same time last year, Public Health Scotland changed the way they done things, and it made our performance look worse at the time because they took out planned attendances to ED. This time round, there has been a change, and I don't know what's driven that, but they've added planned back in, which has led to, or partly led to, that increase.
Okay, thank you. I mean, the delayed discharge still looks like a problem, but I'm aware that there are things happening to deal with that. I wonder if Gail could say a wee bit more about that.
Yeah, so the 4-hour access standard and delayed discharge performance is very stubborn in Forth Valley, and you know that can be reflected elsewhere in Scotland as well. There is a huge amount of work ongoing around supporting whole system flow and recognising that those 2 indicators are signals of performance across the whole system, so not just what's happening and the good work that happens at the front door of the hospital, and not just about how the good work again that happens through our Home First teams in terms of supporting people home, but it also is impacted by the pathways we have in our communities to support people to stay well and healthy as well, and help people not to need to go into hospital. So it's a really complex situation and multifactorial in terms of what drives those indicators. So we did see, in terms of delayed discharges, we saw a slow but steady improvement between May and November 2024. Then, as a result of the budgetary grip and control measures, we saw a deterioration in performance, which we can directly attribute to the financial availability. So that was really helpful in terms of evidence and information to help guide our future planning. So as a result of the significant deterioration, we did take, we amended the grip and control measures to allow greater flow to happen. Again, that's really informed the work that we're doing at the moment. So across the whole system, there's a lot of work ongoing to support whole system flow. That includes the frailty at the front door service that is now available, so people can receive support if they're going down a frailty pathway very quickly and hopefully return home much quicker than they would have in the past. That's very new. It's just been live the last couple of weeks. In addition to that, the shifting the balance of care closer to home, which is a paper is on the IJB papers to be discussed next week. That's a whole system piece of work, which is around moving resource, financial resource and capacity into the community to support people to come home quicker, and also using the discharge to assess approach, which we've been testing since the turn of the year, to allow people to be assessed for their future care needs in their own home, supported by a range of professionals, including rehabilitation, to help more accurately assess their future care needs. And that's just in its second week of testing at the moment, but we're seeing some early indicators which suggest there's some good outcomes for people as a result of that, and we do expect that to have a positive impact on our performance, delayed discharges as well.
Thank you for that, Gail. Yes, I think that the general public would all generally say they like to get home as quickly as possible, and anything that can improve that is in their interest as much. It's not just about the figures, it's about what people are experiencing. So thank you for that. Just another question I wanted to raise was about the sickness absence. Do we have any understanding of the reasons for the deterioration in sickness absence figures, and is there actions being taken to try and deal with that? I'm not sure who I'm pointing that one at. I think you've got your finger on your button.
Yeah, I'll come on that. So sickness absence, again, is another thing that we're very focused on across the partnership. Again, it's one of these really sticky things, and it's really important to understand the reasons for that. And there'll be a range of reasons that are absolutely valid. You know, our workforce are all human beings, and unfortunately we get sick sometimes, and we need to take the appropriate time and recuperation off. I think there's been some the work that's been done around in particular the nursing, in terms of over recruitment of the newly qualified nurses, is helping us make sure that we've got the right amount of staff, and the safer staffing work as well. We've got the right amount of staff to make sure that people are properly supported and they don't feel overstretched in terms of the valuable roles that they do. But it is an ongoing piece of work, and all the heads of service and the operational leads are very focused on how we support people to, like we do with our wider population, to remain well and healthy and able to fully undertake their roles.
Thank you for that. And yes, I think we're all aware of the levels of stress and the demands that are on our staff. So it's not. It's really important that there's work to support them and to keep them as well as possible. Councillor Flynn.
Yep, thank you, Chair. You stole my question there just now, so thanks for getting in early. But I do share the concerns, because I know since I came on the IGB, I've raised the question of absence a lot, because nobody, complains or criticises anyone that's genuinely sick, of course, absolutely not. But if 10% of people are absent, then that means the pressure is on other people that are at work. But the question I want to just really, not more a clarification, is on page 128. It highlights near the bottom, a dispute around grading and pay, unresolved uncertainty may be affecting the morale and resilience of home care staff. I don't see, if somebody's upset about the pay and etc., that is not a medical reason as far as I'm concerned to be absent from work, or have I got this wrong?
Gail, can you answer that one?
Yeah, so there's been a piece of work ongoing probably for over a year now around home carers and their grading. They felt that they had been inappropriately graded. So the roles have been regraded and they have come out at a higher grade. So they've gone up a full grade. The home carers will be receiving the upgrade in, I think it's a June pay, with back pay till April. There's still conversations ongoing around any back pay and incremental points. So while, as you say, that it doesn't make you, there's not, well, there could be a view that doesn't make you ill if you feel that you're not being paid the right amount. That might make you feel stressed and unhappy. So it could contribute to maybe not feeling well enough to come into the workplace. I suppose it's a difficult one, that, but there is a view that if people are not happy in the workplace, they don't feel that they're valued enough, that might lead to higher sickness absence levels.
Okay, thank you.
Thank you, Gail. That answer all your questions? In that case, I'll move to Roger.
Thanks, Chair. Just like been said, we're pretty disappointed about the absence levels, the sickness levels, and certainly my experience is that the pressures are a factor in that. Stresses, people feel that they have to meet the same level of service as they did before cuts, and the pressure of cuts and the way the threat of cuts are on them, and then of course people go off sick and they feel that they have to cover the work of the person who's off sick as well. My view is that we need to be pragmatic and say X number of people should only do X number of pieces of work, and we need to feed that back down to frontline staff, that if people are off sick, they can only do the same amount of work that they were doing before. They might jiggle around the work to prioritise, but we need to be careful that they don't try and take on the excess work.
I think that's an important point. There is significant research evidence that shows that stress and low morale do make people ill. We know that, and I think the nature of the workforce that we have, it is people who really care about what they're doing, and so the people who are left do try to deliver for the public as best they can, and that adds to the stress. I think that's a really important point, Roger. Anyone else have any questions or comments? No, in that case, we've considered and commented on the report, and can we note that appropriate management actions continue to be taken to address the issues identified through this, and we'll look forward to hopefully seeing improvement as management actions are taken.
Agreed.
Agreed?
Agreed.
Okay, thank you very much. In that case, we can move on now to the annual risk management performance report. I think we have Hugh online here for this report.
Good morning.
Welcome,
everyone.
Hugh.
Thank you, Chair. Good morning, everyone. This is the annual report for April of last year to March of 2025. The report has been considered by service management team, and the action plan at section 1.4, we have agreed those actions. So there's some movement since the report. The key messages within the report are there is limited assurance and progress with the risk improvement plan. That's a plan which we've had for about 3 years since an internal audit. The main reason for that is the delay in service restructures, so it has taken us a lot longer to move forward the actions which we know we need to take next, but that has started to move, and I'll give some examples later. Whilst there is limited assurance in relation to risk management action plan, we do emphasise that there's lots of assurance which you receive in our reports, and you see that in your reports today, such as reports on clinical and care governance. So it is always difficult giving limited assurance in one area when we know there's lots elsewhere. Within the action plan itself, at section 1.4, there's just 3 key actions I'd like to highlight. The first one is the strategy will be reviewed at the end of this year. As part of that, we'll be developing risk appetite statements and developing some practical ways to build that into development sessions with elected members, board members, and senior management teams so that it becomes practical. We'll also be undertaking focus reviews, which is looking at each one of the strategic risks in a lot more detail to make sure that we have a proper assessment of the risks, the controls, the actions, and that we start to be a lot more specific around those actions, such as timescales and progress. The first focus reviews are going to take place next week. We're starting with resilience, and then over the next 6 to 8 weeks, we'll be looking at workforce information management, including cyber and digital assets, which includes premises and estates. And my colleague Vicky in NHS will also be looking at assurance and governance. And so we also be doing a review of resilience and business continuity. So I hope that gives you some reassurance that whilst it has taken a long time to get things moving, we are starting to move and will get hopefully reports turned around within the next 3 to 6 months. And the other key action I'd like to highlight is around training. There is already a lot of development sessions work for both employees and board members. What we're trying to do is embed risk management into those wider sessions. So, for example, recently we completed risk workshops with operational managers within social work. The next stage is to embed those actions into improvements, for example, data integration, so that managers aren't duplicating when it comes to risk updates, but we're actually embedding it into normal performance reports. And just to go back to recommendations, those are to ask board members to scrutinise the report and to note that an update on the improvement plan will be included in future quarterly updates. And myself and the leadership team are happy to take any questions.
Okay, thank you very much, Hugh. And once again, I'll say it's good to see that there has been some improvement in a number of areas, but it is limited. Moving from no assurance to limited assurance certainly is the right direction, but we need to go much further. Does anyone have any questions for Hugh or anyone else on the team? Roger?
I just wanted to thank you, because my feedback from social work managers was that the training they got was very positive, and they felt it was really useful. So thanks for that.
Thank you, Roger. That's very good to hear. Maybe that will deliver improvements. Let's hope so. Lee?
Thanks, Chair. I was just going to say thanks to Hugh for bringing forward the report and presenting it. Just to recognise, we would have liked to have moved on a bit further than we have at this point, but actually Hugh's providing that assurance that things are moving now. We've got those deep dives coming, those focused reviews around the strategic risk register. So I would hope to see a lot more movement coming forward for this financial year. And also we're going to be recruiting the business and governance lead very soon as well. So they will actually take on responsibility around risk management and assurance as well. So we're hoping that extra capacity will absolutely help with moving things forward over the next financial year. Thanks.
Thank you, Marie. I apologise if what I said sounded very critical, but I do recognise that there has been improvement, and I recognise that Hugh has talked about the different things that are being put into place to ensure that there is further improvement. And we're all very glad to see that. And we look forward to seeing follow-up reports that will make us smile. Any other questions or comments? In that case, can we agree that we have fulfilled the recommendations of scrutinising the annual risk report, and we've noted that a progress update will be included in future quarterly risk updates?
Agreed.
Agreed. Thank you very much. So moving on to the next item on the agenda, which is the IJB Strategic Risk Register. And I think this is yours, Marie.
Yes, thank you, Chair. This paper is the normal update on the IJB Strategic Risk Register that comes to each meeting. No new risks have been added to the register since the last version presented to the Performance Audit and Assurance Committee in March. There are currently 9 live risks recorded in the register. 1 is considered very high risk, being finance, 7 are high risk and 1 medium risk. The current IJB Strategic Risk Register will be maintained and reviewed on a regular basis while the changes that were previously reported are set out and those focus reviews move forward. And as they happen, we will update the register as we move forward. The IJB Audit Committee, Performance Audit and Assurance Committee are being asked to consider and comment on the high-level summary. And I'd just like to highlight a few changes since last time. Starting at 4.6, so a number of key considerations in reaching the conclusions are noted below. So for Strategic Risk 1, Financial Sustainability, this has been updated in relation to the agreement of the medium-term financial plan in March by the IJB, and implementation of the Finance Oversight Group has been added as a future control, and these are due to begin, and it says May in the report, but actually the first meeting is actually going to be July, so I apologise for that. That's actually moved to July. So that first meeting will take place in July, and I'll update the register to say that. Implementation of the new integration scheme will be moved to a current control following sign-off by Scottish Government. That's been submitted, and we're currently working through some queries that have come back from Scottish Government. So once that happens, that will be moved to a current control. For governance arrangements, updated to reflect finalisation of the Audit Committee self-assessment and implementation of this new committee. For partnerships, it has been updated to reflect ongoing work with locality plans and with the East Locality Plan, which will be presented to the IJB. In relation to commissioning, the current controls have been updated to reflect the appointment of the new commissioning lead in April. And also a new user intelligence group will be convened to move towards a new care and support at home framework from April 26. Around resilience and business continuity, Hugh's mentioned this today already. The Council has hosted some training and also a third and final Care for People framework exercise for Forth Valley in March. A resilience workshop was held on the 2nd of May for a senior management team to test the current plans and HSCP's response to a major incident. That was supported by NHS Forth Valley and Falkirk Council resilience partners as well. The HSCP communication strategy around major incidents is also being updated in tandem with the session in May. Primary care sustainability, it was agreed to align the NHS Forth Valley risk for primary care sustainability to reflect the same as the IJB Strategic Risk Register, so that's now happened. And also, Hugh has already mentioned that risk strategy is due to be reviewed this financial year by March 26. I'm happy to take any questions on that or in the appendix. Thanks, Chair.
Thank you, Marie. And I think we need to recognise a huge amount of change that has been going on over the last wee while and is still in process. So for those changes to impact on our reporting, it does take time, and we have to recognise that. That said, it's still obviously a matter of concern that things are appearing as so many things are appearing as very high or high risk, and we look forward to some improvements over time as the changes get bedded in. Does anyone have any questions or comments? Roger?
Thanks, Chair. Just very quickly, at 4.13, it says that I've moaned about this before, but the home care redesign, which has been going on for years, has been halted. Any idea when this is going to start again?
Sorry, Gail, yes.
So this is linked to the recruitment of the care at home lead. I'm wondering if Caroline might want to just come in and just say a few more things about that.
Thanks, Gail. Thanks, Chair. So in terms of the recruitment, we've been successfully identified a preferred candidate and they're due to start mid-July. I would anticipate then that their priority would be about re-establishing the care at home redesign. I think what we need to do is we need to get all stakeholders in the room and really reset the programme, Roger, and think about how we take it forward, because we need to think about what we really need the service to deliver, and also we need to be cognizant to the financial situation that we're now in. So we need to be clear about what we're actually taking forward and what the plan is. And I'd like to agree that with all the stakeholders, along with the care at home lead, who'd be taking it forward. But just to be reassured that this would be our priority, Roger.
Thanks, Caroline. Just to reiterate that there's a lot of anxiety amongst staff due to this.
And presumably all the trade unions are among the stakeholders who will be involved in the discussions. So we look forward to hearing positive reports once that gets moving. Thank you. Any other questions? I think just a further comment that, I mean, clearly the one very high risk is our financial sustainability, and that is no fault of the staff. It's in the situation that we're in, and in fact, a lot of staff have been doing a lot of good work to try and improve that situation. So, thank you for all that hard work. And I think Roger's point is important. The care at home is a fundamental part of the whole system. As Gail was talking earlier on about the whole system approach, care at home is key to making everything else work in the system. Okay, and if there are no other comments or questions, can we say that we have considered and commented on the summary, and that we note the ongoing work to the changes proposed and reported to PAC in March? Is that agreed?
Agreed.
Thank you very much. And at that point, we will move on to the governance statement improvement actions. I think this is back to you again, Marie. Oh, sorry. Oh, sorry, have I missed one? I'm jumping. My apologies, Marie. We're at the National Audit Report and Inspection Overview. Sorry. That's my wishes to get through this quickly. I can't jump the items on the agenda.
Lots of items to get through. Thank you, Chair. This report provides an overview of the National Audit, Scrutiny and Inspection reports published since the last meeting of the Performance Audit and Assurance Committee held in March. A total of 2 national reports have been published since the last meeting by Audit Scotland, 5 by the Care Inspectorate and 6 by the Mental Welfare Commission. The committee are being asked to consider and comment on the contents of the report. And I'd just like to highlight a few items. So at 4.4, the 2 national reports that have been issued are the Local Government in Scotland Financial Bulletin for 23-24, and some of the key messages are set out at 4.4 and the recommendations at 4.5. I don't think that any surprises on the other. It's areas that have been highlighted for some time. So at 4.4, it's highlighting increasing resilience on savings, which are becoming more difficult year on year, reliance on use of non-recurring reserves, continuing constraints on capital funding for local government, and the need to intensify transformation activity, progressing at scale and pace to ensure financial sustainability. And the recommendations in that report are set out at 4.5. Including reporting more comprehensively on savings, ensure impact of capital finance and flexibilities are reported clearly, and to ensure reserves policies indicate clearly the impact of financial flexibilities. More particular for the IJB, from 4.7, there was an Audit Scotland report on IJB Finance Bulletin 23-24, so it's just important to note this was around 23-24 financial year. This has already been circulated to members and it's been highlighted in the medium-term financial plan as well. So some of the key messages in that report were around that IJB finances continue to be challenging, with funding increases in real terms compared to 22-23, but a concerning picture of continued overspending, depletion of reserves and savings being met through one-off rather than recurring measures. The majority of IJBs have reported a deficit in 23/4, including ourselves at 7.5 million. Contingency reserves have almost halved over Scotland, limiting the ability to address future deficits. The majority of planned savings were achieved for 23/24 across IJBs, but a substantial proportion were achieved on a one-off basis, causing additional pressures for future years. The financial position set to worsen, a projected funding gap at that point of 457 million, of which the Falkirk element of that was 18.429 million. The continued high turnover of chief officers and chief finance officers was also highlighted, and the recommendations include that the IJBs need to work collaboratively with each other and with NHS and council partners to find ways to transform services. Investment in prevention and early intervention is needed to help slow the demand for services and the cost of complex care and improve outcomes. So that's some of the recommendations and main points in that report. Around the inspection reports, there were 5 Care Inspectorate reports and 2 Mental Welfare Commission reports published which relate to Falkirk services, and these are listed in the table at 5.4. The Mental Welfare Commission also published 4 reports in relation to mental health services across Forth Valley. A separate, more detailed report is on today's agenda in relation to the recent Care Inspectorate inspections of our internal care homes, but we've got colleagues here who can answer questions around these reports as well. I'm happy to take any questions. Thank you.
Thank you, Marie. I think we're all well aware of the serious financial situation for both local authorities and for the IJB, and recognise the reports and the things that they are highlighting, recognise the problems and the solutions. Although I think sometimes it's difficult to find a solution when you have increasing demand and static resources to deal with that demand. There's only so much that transformation can achieve. Does anyone, I think, since there's a more detailed report on the Care Inspectorate reports, shall we just leave that to the detailed report rather than taking questions just now, and just looking at the more general reports at the moment, which I find very useful, if rather depressing. Any other questions or comments? So in that case, we have considered and commented on this report, and we'll come on to the Care Inspectorate reports when we come to that item on the agenda. Agreed?
Agreed.
Thank you very much. So we'll move on to item 13, which is the IJB Committee Annual Assurance Statements. And once again, back to you, Marie.
Thank you, Chair. This report presents the Audit Committee, Clinical Care and Governance Committee and the Performance Audit Insurance Committee 24-25 Annual Assurance Statements for approval. We've brought these together because we've had the changes in committees during this year. We've brought these together under one cover report, but each appendix sets out those assurances and the information required for each committee. So we're asking the committee to approve the annual assurance statements attached as Appendix 1 to 3 as follows. For IJB Audit Committee from 1st of April 24 to 16th of January 25, the IJB Clinical and Care Governance Committee from 1st of April 24 to 16th of January 25, and the joint work of the Performance Audit and Assurance Committee Annual Assurance Statement from 17th of January to the 31st of March 2025. The statements provide assurance to the IJB that the committee structure supports delivery of strategic priorities and ensures that operational and strategic risks are being managed effectively. The statement covers the previous year Audit Committee, Clinical and Care Governance, as I said, and the newly formed PAC Committee. I'm happy to take any questions on that. I wasn't intending to go into any more detail. Thank you.
Thank you, Marie. And I think it's helpful to bring together the reports in the way that you have done here. Does anyone have any questions or comments? And if not, can we approve the annual assurance statements in appendices 1 to 3?
Agreed.
Agreed. So thank you very much. And we will move on now to the item 14, the governance statement improvement actions.
Thank you, Chair. This report provides an update on progress to implement a range of improvement actions identified through the annual governance statement and from various internal and external audit report recommendations. The committee is being asked to consider and comment on the progress report on improvement actions set out. Note that the previously completed items have now been removed from Appendix 1 as agreed at the last meeting. I'll just provide a few updates on the main areas. So in relation to the integration scheme set out at 4.6, since last reported, the Falkirk Health and Social Care Integration Scheme has been approved by NHS Forth Valley, Falkirk Council and endorsed by the IJB. The integration scheme has been submitted to Scottish Government and initial feedback has been received, and officers are working through the queries, and further update will be provided when the final scheme has been approved. In relation to the Ministerial Strategic Group self-assessment, following previous work carried out in relation to the assessment against the Ministerial Strategic Group recommendations, a review of the previous findings and next steps will be agreed as part of a June session. So we've actually held that IJB development session now, and we're now taking away the findings from that session and circulating to IJB members and Strategic Planning Group members as well for feedback. So a report will be brought back to the Performance Audit and Assurance Committee in due course, hopefully to finalise that self-assessment work. For other internal and external audit actions, previous actions marked as completed have now been removed from the appendix, as I've said. Updates have been provided for each remaining action on the appendix. We updated target dates in line with responses for the internal control evaluation, which Anne-Marie presented earlier, and the draft annual governance statement and the annual accounts document. I'm happy to take any questions. Thank you.
Okay, thank you very much, Marie. Having attended the IJB development session, I find it very, very useful to have a deep dive into some of the issues. And I look forward to the report coming forward. Are there any questions or comments? We're doing very well today. In that case, we have considered and commented on the progress report on improvement actions. And we noted that there are items that have been removed as agreed when they've been completed. We agree the recommendations. Agreed. Thank you very much. I think at that point we may take a break because we've been going now for an hour. So we'll have a comfort break and enable the technology to be checked for the next item on the agenda. So it's now come back at 2:45, or that fine? 11:45 we'll return. Thank you very much. Okay, welcome back, everyone. Hope you enjoyed your cups of tea or coffee or whatever it was that you took time to get. This is the continuation of the Integration Joint Board Performance Audit and Assurance Committee, a mouthful. And we're moving on to item 15 now, the internal care home focused assurance. And Kirsty Nightingale has joined us to present that report. And after the report, there'll be a wee video for everybody's enjoyment. Over to you, Kirsty.
Thank you, Chair. This report provides an overview of the Care Inspectorate's recent unannounced inspections across all 5 internal bedded care homes within Falkirk Health and Social Care Partnership. It outlines the key findings, highlights examples of best practice, and identifies areas for improvement, particularly in relation to staff training systems. The Performance Audit and Assurance Committee is asked to note the Care Inspectorate findings across the homes and also recognise the positive impact of the Safer Together collaborative. The 5 internal bedded care services were inspected between January and April 2025, with Summerford House being inspected within the new inspection year, so they were inspected on different key questions. Burnbrae, Cunningham House, Grahamston House and Thornton Gardens were all inspected on key questions 1.3, which is how well do we support people's wellbeing, and 3.3, how good is our staff team. I'm proud to say that all received grade 5s, which is very good for both wellbeing and staffing. Summerford House, as I said, was inspected on the new inspection year, so they were inspected on key question 1.3, how well do we support people's wellbeing, and 4.1, people benefit from high quality facilities. Once again, I'm proud to say that the grades were received for 5, for very good for key question 1.3, and a grade 4, which is good for key question 4.1. And all services were positively recognised for implementing person-centred and proactive care models supported by multidisciplinary input and current guidance. A summary of the strengths across all the inspections is included in the paper, but for a quick overview, the residents all received care that upheld dignity, promoted independence and offered choice, and that personalised support plans, safe medication management and appropriate health interventions were observed in every home. Staff demonstrated a high morale, effective leadership was visible and teams were praised for their engagement and responsiveness, and staffing levels were determined by real-time assessments. Meal times were dignified and tailored to the individual preferences, and residents participated in meaningful and varied activities, many of which were linked to personal interest and social wellbeing. And all homes maintained excellent standards of cleanliness. Summerford House was noted for an area for improvement through one environmental concern. The issue that was identified was one of the 4 units was found to be too cold, and this was confirmed by one resident and noted by the inspector. The reason for this, we believe, is that the radiator had been turned down due to the other residents complaining about the heat. However, it is important to note that one of the boilers is also out of operation, which may have contributed, and this means that the heating isn't working to full capacity. However, a replacement has already been scheduled for this year, and the inspector was reassured that the home remains within safe temperature ranges and that we'll put an action in place. Whilst there was no area for improvement around for any other homes, there was a concern raised around staff training compliance, and it was noted as an area to look at across all the homes. The inspector noted that there was a lack of consistent system-wide approach to monitoring training compliance, meaning that there was a difficulty in obtaining an overview of staff training status across the service. In response to this, we've created a new centralised training matrix, and this has been piloted across the homes, and we're working together to continually review and improve this. We have shared the new matrix with the inspector post-inspection, and the early feedback from them has been positive. It is important to note that the inspector stated that if a clear and consistent implementation hasn't been implemented by the next inspection cycle, formal recommendations may be given. The inspector also praised Grahamston House in particular as a model of evidence-informed practice for their quality improvement work as part of the Safer Together collaborative. The inspector noted that the efforts of the full team have demonstrated leadership in proactive and preventative care. The project was to reduce falls within the home through movement. It was developed in partnership with physiotherapists, residents, families and the staff teams, and its aim is to use a structured strength and balance programme to reduce falls. And I'm pleased to say that the early indicators show reduced fall risk and improved resident mobility. As part of the Grahamston House project, a video was produced by the lead of the project, who's John Vaughan, one of our senior social care workers. The video features a resident who participated in the falls prevention programme, family member who describes the positive impact of the initiative, and the full staff team are seen to be enjoying the project and enjoying implementing the changes. And it is with great pride that we share this story. The resident featured had a personal goal to be the leading lady in a movie. Though she has sadly passed away, we are proud to have fulfilled her wish in a meaningful and lasting way. And I hope you enjoy the video. Thank you.
Thank you, Kirsty. Should we take questions just now or go straight into the video and questions afterwards? I think go into the video first. You've given it you've talked it up, so I'm desperate to see it. Don't worry. Technology is always challenging. Bear with us, please, everyone. It's just trying to overcome the technical difficulties. After all that building it up, I'm going to be really upset if we don't get to see this video. Here it is. Thank you.
Hello, my name is John Vaughan and I'm a senior social care worker at Grahamston House, which is a 32-bedded care home for older people living with dementia and various other conditions. A quick fun fact before we start. The introduction meeting that I had to begin this journey was with Claudette, and it just so happened to be on Halloween, where all the staff were fancy dressed, and I ended up having to do the meeting dressed as a police officer with a very uncomfortable moustache. So in order to achieve our work stream aim, we hope by November 2025, 100% of our service users who are at high risk of falls will engage within personalised physical activity, reducing falls by 17%. This number can be variable depending on who is high risk month by month. And our theory of change would be to engage 100% of our high risk residents in daily personalised physical activity sessions to enhance mobility, strength and balance and reduce the risk of falls. The background story started early on when we introduced a falls checklist that asked questions our current incident reporting system didn't ask. making the information easier to access and record this data. Each month we completed a falls audit. This info is placed into our recording spreadsheet and a Pareto chart. On further reflection with the data that we gathered, we were able to zone in on individual residents who were having frequent falls. In 2024, we had a total of 186 falls. 101 of these falls were actually sustained by 5 individuals. That's 54% of last year's falls. So 100% of the 5 residents did not engage with physical exercises. They were sitting for longer periods, not mobilising as often as they previously did due to a decline in their health and dementia. Our theory of change was to introduce daily exercises to the high-risk residents who were having frequent falls. We advertised sessions for staff and relatives to attend exercise sessions with the NHS physiotherapists. These were 4 simple and easy exercises that focused on strengthening the upper leg muscles that previously these residents were not engaging. The classes were well attended by both staff and relatives and residents, and were also fun. By inviting relatives, this meant that they were part of the care and improved well-being. The staff were also quickly realising how easy and quick these exercises were to do. The exercises were safe, did not pose a risk of falling, as they were all done sitting on a chair. At the end of each session, everyone left feeling encouraged and very positive. Each high-risk resident had their own exercise booklet, which was designed using photographs of one of our social care workers, Adele, who the residents would recognise and relate with, demonstrating each exercise. The booklets were also designed for ease and quickness in mind, and to accurately record the completed sessions. It was agreed that the exercises would be completed 3 times a day and would take a few minutes to complete these sessions. These sessions could be completed as a group or individually or with family. We encouraged sessions to be fun and person-centred, playing the residents' favourite music and adding props. The information is measured weekly, and this is then placed into a further recording spreadsheet. We try to get all staff involved, from relatives, managers, seniors, activities coordinator, and domestics. Any exercises that are completed are recorded in the residents' exercise booklet. However, after 3 weeks of starting, we did note that figures of the recording had dropped, but the number of falls had also significantly dropped. In February, we had a total of 6 falls, compared to previous months of 17 and 19. Although staff had not always been recording the exercises, their awareness of falls had increased, and the high-risk residents were moving around more frequently compared to previous months. To overcome the lack of recording, we've introduced a rota system where this is a scheduled activity. We also have a monthly falls huddle and discuss each individual incident. This then determines who needs to have exercises introduced and if there is any other safety measures that could be introduced to prevent falls with harm. It is vital to factor in the human element of this project. Some of the residents became physically unwell. One resident deteriorated, and the cognition and mood of the residents at the time of the exercises was also a huge feature. The QI tools that we have used so far. We used a stakeholder analysis. This told us the key people who would be involved in our project. We completed a project charter that outlined the aims and objectives and agreed on how we were going to meet our aim. A driver diagram to provide clarity on the areas of focus, Pareto charts and run charts to help identify areas for improvement, and we continue to use the PDSA as we are still learning and adapting our ideas. This leads us nicely into our testing change stage. We initially began by finding our baseline, what our number of falls year to date was. Then we posted and collated data from a staff survey, which included the paperwork, processes and procedures, confidence with supporting residents who had fallen, and how the staff wanted to be supported to lead the change. From here, we set up training classes, providing staff with re-learning modules for falls, fractures and bone health, as well as falls prevention. We were then supported by the NHS Forth Valley Reach Physio with our training programme for staff on exercises. Although we were still very early in our project, our biggest success so far has been the feedback from relatives, and we also was graded a 5, which was very good, from the Care Inspectorate for how well do we support people's well-being. The Care Inspectorate spoke about this in their formal report, and we were working on a project aimed at reducing the number of falls people were having. The Care Inspector was also able to witness the exercise training session, and she joined in.
Good afternoon. This brief video is all about maintaining your joints and a sense of humour, more importantly. My name's Tom and I'm star of the show. So pay attention. We'll start in the middle. Just like in real life, where mobility starts to go wrong there as well. Here at Graveston House, I've seen a big improvement in all the participants taking part, up to date. Now, using the doable illustrations that had been provided and the care staff that's available, I'd further improved the episode by introducing a rhythmic music at the slow but regular beat. However, don't be tempted to speed it up like I tried to do the last time when I had to fight off an undertaker as there was no ambulances available. Get the picture? Make the whole purpose fun and find future episodes be regularly and well attended. Please enjoy. Tom.
Right. What do you think of exercising?
Oh, not a lot.
And what's the benefits of exercising?
Well, it's the strengthening your muscles.
And does it help your mobility?
I do it sometimes. Not a lot.
What do you like about doing exercises?
Well, I think it keeps you it keeps you into the health business. You know, it keeps you healthy.
What's next? We plan to continue to focus on one unit at a time based on the residents who are likely to engage. To launch our exercise sessions in the rota, looking at introducing the falls champion to aid this, and to look to re-enthuse everyone with the hope of gaining that enthusiasm and positivity moving forward. I'd just like to thank everyone who has helped us on our QI journey so far. Claudette and Scott from the QI team, my colleagues Linda and Chris, Sasha from the Reach Physio, Lisa Falls Lead from the Falkirk Health and Social Care Partnership. Thanks everyone for listening.
That's lovely. Thank you very much. The only thing that was missing from it was the music. Should have had the music on. I'm feeling like getting up, doing a wee bit of exercising. It's got me going. Thank you. Does anyone have any questions they'd like to ask or comments? Roger?
Thanks, Chair. And now I just, in my job as a mental health officer, I go around to quite a lot of care homes, both the in-house ones and the private ones, and I really do notice the effort that the staff put in our in-house services. The difference, the forward thinking is a step change from some of the private care homes that I go around. So I think it's a relief for many staff to find that the care inspection has come out and recognised this, because it's always an anxious time for staff when they go through these, because it can feel a bit sort of random sometimes, the inspections, but there's a huge relief, and I mean, I would really want to support the hard work that the staff have put in and recognise that the good quality. Thanks.
Thank you, Roger. Councillor Flynn?
Yeah, thank you, Chair. I would just like to say I found that video heartwarming, encouraging, and incredibly positive. You know, for the staff to get involved with the enthusiasm they have done and to monitor things, and at the end of the day, to see the number of falls reduce, absolutely incredible. Really, really good indeed. And of course, it has a knock-on effect where serious falls might end up in the emergency department. So there is a benefit there. So well done to everyone involved. Absolutely brilliant. Thank you.
Thank you, Councillor Flynn. Can I ask, are there any plans to roll this out across other homes? Because it seems to me that that the figures in terms of the reduced number of falls are quite startling. So I think we need to be doing more.
Yes, so the plan is that next month we're going to start rolling it out across all the homes and also the community hospitals. So senior social care worker John Bonds agreed to be the lead for that. So part of the Safer Together collaborative where we are now, so the project ends in November, and now we're looking as a collaborative around the spread. So all the good pieces of work that are going across the whole partnership, how do we now start putting those out across? So we plan on this piece of work to start from August.
Excellent. I think maybe going back to the report, I think we need to make comment on the fact that on all bar one point, all the homes were very good. And I think we need to say a very big thank you to all the staff and managers and everyone who's been involved in looking after, and particularly given that these were unannounced inspections. So we getting things as they really are. So well done to all of the staff for achieving that fantastic level of inspection, and I'll look forward to it being excellent next time. to be fair, I always worry about an excellent finding because that suggests there's no room for improvement, and there always is, as you have just demonstrated with your little video. Huge improvement there. Well done. Any other questions or comments? I mean, I haven't been to all of the homes, but I have been to Grahamston, and I've been very impressed by the work that goes on there. And I would recommend for others that if they get a chance to have a visit to some of the homes and see the really good work that's going on. Okay, in that case, can we note the inspectorate findings and recognise the positive impact? And I think, could we add a recommendation that we want to say a big thank you to all the staff who have achieved this? Is that okay
Agreed.
with everybody?
Yep.
I think that should be recorded because there clearly has been a huge amount of work done there. Okay, thank you very much. Thank you, Kirsty. That will be us moving on now to item 16, the Clinical Care and Governance Management Group report.
Yeah. I feel pressure now following on from that. I almost feel that should have been the last item on the agenda to finish on, but thank you. So yes, this is just the regular update that comes from the Clinical Care Governance Management group that you have in front of you. I won't go through the whole report, but I'll pull out some highlights for committee's information. So in the last reporting period, there were 4 unannounced care assurance visits across the healthcare areas within the partnership, including community hospital, community nursing and prison services. All returned a result of significant assurance with no areas of concern escalated. During the meeting, as normal, we also explored the safeguard reports and care inspectorate notifications and looked for any emerging themes or trends, and pleased to say that there's no unusual trends highlighted in either of those areas. Work is ongoing as well in relation to scoping out our current health and social care partnership policies, which will include identifying renewals required as well as any gaps The work will also include reviewing what we can use from partner organisations just to reduce that duplication of effort where appropriate. In relation to adverse events and learning reviews, there were 3 adverse event briefing notes that were considered within the adverse event review group. They were highlighted to the clinical care governance management group. So 2 of those related to falls with harm within our community hospital settings, and 1 related to a grade 3 pressure ulcer, which developed within the community setting. But none of these adverse events were assessed as requiring further escalation to the shared intelligence group. So we've not escalated anything up to that group in the last reporting period from the AERG. We also had an update from the Head of Community Services in relation to work underway to streamline the significant occurrence and adverse event reporting arrangements. So this will support a standardised process for staff across all of the health and social care partnership services, as well as clarifying roles and responsibilities, whilst again reducing duplication of effort moving forward. And we'll have a further update on that work in the August meeting. At 4.14, you'll see that there was 2 deaths in prison learning and reviews. So DIPLARs held in the last reporting period relating to 2 deaths across Forth Valley Prison Estates. And just to provide assurance that learning and improvement opportunities have been agreed and will be monitored through the clinical care governance management group as appropriate. And as is their policy with all deaths in prison, these deaths will also be subject to fatal accident inquiries in due course. In terms of external inspections, we've already obviously heard the great work from Kirsty's team, and as Marie highlighted earlier, there have been 2 published reports from the Mental Welfare Commission. These relate to HMP Pullman and the Bonus Ward 2. The teams have been developing improvement plans, and they have been submitted just in the last week or 2 to the Mental Welfare Commission, and the details of those improvement plans will be included within the next report. We also had an update from the Adult Support and Protection lead officer. She attended the CCGMG and gives an update in relation to interagency referral discussions. There's been a lot of work that's going on in that area in terms of getting the process right and also auditing the quality of the IRDs that take place. So the group were given quite a detailed update in relation to the activity there. It was highlighted during this update that 63% of IRD documentation that has been audited has been rated as either good or better and is continuing to improve. It was noted through those discussions that whilst the cases that go to an IRD were audited for that quality assurance piece, the adult support protection referrals that were put in that didn't go to that stage weren't audited in the same manner, so we didn't have the same level of assurance in terms of the quality of documentation and activity that happened out with the IRD process. So the lead officer agreed that she would go away and build an audit process similar to the cases that don't go to IRD, and again she would bring that back for a further update at a future meeting. In terms of risks, there are some risks from 4.28 down to 4.34 in the report. Some of them have been brought to committee's attention before, but just one update that I wanted to give in relation to 4.28. So it's been raised over the last few management group meetings that there's been difficulty in staff across partnership areas accessing research training. There's been a limited availability in terms of the number of places available, and some of the courses have been cancelled at the last minute, unfortunately. So I have raised that in my role as chair and also chief nurse to the appropriate people, and I'm pleased to say that there's been extra dates that have been added and there's been extra places made available that some of our colleagues across the areas have managed to access, but we'll continue to monitor that through these routes. And finally, just in relation to future steps, so obviously Children's and Justice Services have now moved across into the partnership. So moving forward, the membership of the CCGMG will include representatives from Children's and Justice Services as well as the Chief Social Work Officer and it's likely we'll have some discussions, and it's likely the Chief Social Work Officer will take up role as co-chair. We've got the Chief Nurse and Chief Social Work Officer and professional roles chair. So I think I'll leave it there. I'm happy to take any questions that you have.
Thank you, Nicola. I think maybe first just comment on the deaths in prison. Clearly, that's the saddest part of the entire report, and our hearts go out to the family and friends of the two people, and it really is vital that we learn the lessons so that these kind of things can be avoided in the future. Apart from that, I wanted to ask a wee bit more about the mandatory training. That paragraph kind of jarred a little. We have mandatory training, but people can't access it. This seems really, really big concern. And you're saying that there's actions being taken. At what stage are we at in terms of having ensured that everybody has had access?
Okay, so the mandatory training sort of activity is managed by all of the service leads in their area. However, following me raising this with the resource team, as I mentioned, they've put additional courses on. What they're also looking at doing is undertaking a kind of train the trainer programme, whereby there'll be individual trainers within all of the services who are trained to deliver that training to their colleagues to make it easier moving forward. Don't have a full plan on that at the moment, but these are early discussions that we're planning on taking forward. What we've managed to do as well, and what the resource team are doing in collaboration with the service leads, is prioritising who needs what. So at the moment, the training is open to everybody, and it's almost first come, first served, which would be appropriate if there's enough for everybody to go round. But because at the moment the spaces are limited, they're looking at prioritising well who would get those spaces. So whose training is still in date, but they're trying to keep it in date, and whose is actually out of date, who actually requires getting that in the first instance. So it is quite complex given the limited availability within the resource team, but we are looking at ways to extend that out with one team, the capacity back into the service.
Thank you. I think this is really important. That can save lives. Absolutely essential. At 4.30, there's mention of workforce issues and the recruitment that's going on. In what kind of timescale do we expect to resolve the workforce issues?
Yes, there's been activity over the last month or so. Caroline's on the call, who's the head of service for this area. I wonder if Caroline might have more detail on the actual recruitment activity.
Thanks, Nicola. So in terms of recruitment it's around like social work and OT workforce within the locality teams predominantly. So we've had a series of interviews and we've been successfully been able to appoint to most of the social work roles, but we've had a real struggle around being able to recruit, increase our capacity around OTs. So we're intending to re-advertise for some of the roles, but meanwhile we've put in agency support pending the people that have been successfully appointed coming into post. So we're actively working in that area to kind of strengthen the capacity around social work and OT, but we recognise that we've got more to do around it, and we're looking at the options around it to look at how we make sure that we're increasing the capacity and supporting the workforce to be able to respond to the demand, but also probably referencing what Roger was talking about earlier, making sure that people aren't having to take on significantly more tasks than normal, and being able to manage the workload. So I'll be able to bring an update probably to the next meeting around that, because we'll be further on in the process.
Thank you very much, Caroline. The next point I wanted to ask about is at 4.32, the care home remaining on an enforced moratorium. having received grades of 2 from the care inspectorate. I wonder if you could say a wee bit more about, because that jumps out as requiring fairly urgent action.
Yeah, I'm wondering if Caroline, again, because she's been leading this work, also just so that you can get that right level of detail. Sorry.
Thank you.
Thanks, Nicola. So in terms, we've met with the provider, and what we're doing is we're supporting them around their improvement work that's required to improve their delivery of care. But we're mindful that we have to also monitor and make sure that the residents that are within the care home are getting the right care and support. So we have both health colleagues and social work colleagues going in and offering daily support around that. So we're fairly confident that things are moving in the right direction around their improvement work, but we have to wait. The moratorium will remain in place until the care inspectorate come in and regrade the home, hopefully being able to recognise the improvement work that's ongoing. But just for the committee, just to be reassured that we're closely monitoring the situation and providing support for improvements.
Do we have any timescales on that?
No, it's up to the care inspectorate to decide when they come back in. So we're liaising with the care inspectorate so that they're aware of the work that we're doing, but we don't get to kind of suggest when they come in.
Okay, thank you very much, Caroline. And my last question is about 4.33, an increase of aggressive behaviour, which is obviously a matter of some concern for our staff. I wonder if you could say a wee bit more about the approach to this and the ways in which we're trying to improve that situation.
Yes, thank you. So this was raised from out of hours colleagues during the management group, but was also substantiated by other colleagues in the room as well. So colleagues were seeing an increase in, distressed interactions that was then deteriorating into what they class as aggressive behaviour from people accessing the services who weren't happy with the length of time they were waiting, or indeed the outcome from their appointments. They wanted a different outcome. So what we'd agreed at the management group was the teams individually were trying to tackle things in their own way, but we'd agreed at the management group is that actually there should be a corporate approach on this, and the communications team should have, standardised messaging and communication and things that we give. So the person who raised it is linking in with the head of communications at NHS Forth Valley, and I believe that there are some standard communication toolkits that we can use, in terms of putting posters up and how we signpost people to the patient relations department if they're not happy and things. So we will get an update from that at the next management group meeting, and I can provide a further update moving forward on this report.
Can I just ask, do we have a robust reporting mechanism so that we are actually recording it fully?
So it should be recorded through our safeguard system. It is relying on individual staff members, however, recognising the need that we should be recording this. So there might be an element of under-reporting in terms of the formal recording, but we have asked staff to be mindful that it should be formally reported through our adverse.
And the other thing, the final question on it is, are there training arrangements in place in terms of ensuring that staff are well prepared for dealing with the situation if it arises? Hopefully we can do something to avoid it arising, but if we can't.
Yeah, so we have first impressions training, which is offered to all staff, and all staff are encouraged to do that as part of their induction. And during the first impressions training, there is an element of de-escalation and signposting and managing those situations appropriately. We just need to make sure that.
Okay, thank you. That sounds like I'm being very critical, but you've been very honest in your report about the risks involved, and we have to address those. Does anyone else have any further questions or comments? Roger?
Thanks. Just on that point, I like so many people have seen a apparent increase in the amount of violent incidences towards staff from service users, and I but I also see that the way it is dealt with can be different in different parts of the health and social care partnership, and in some parts it seems to be more accepted than others. And I think that the idea of having a corporate approach, which is the same across the partnership, would be really helpful in that.
Yes, we're aware of it across the council, in other areas as well as this.
But the unacceptability of it is the same wherever you are in the partnership, rather than some places, some teams feeling that it's almost to be expected.
Yes, I think that is important, and that was why I was asking about the recording, to making sure that staff do report it and don't just accept it as something that they have to put up with. Okay, thank you. Has anyone else got any other questions or comments? If not, then I think we can say we've considered and commented on the update provided, and thank you very much. And we look forward to hearing about the next steps. So that would lead us on to our final report on item 17, which is the Performance Audit and Assurance Committee report to the IJB. Now, I think when this has come up previously, we have perhaps said, does anyone have anything they want to put in it? I think the answer is yes, you do have things that we want to put into this, and we have to decide what they are. So this is about whether we are assured or not by the reports and discussions that we have undertaken today. And we want to confirm any items that we want to be highlighted to the Integration Joint Board via the assurance report. So does anyone have any things that they would like to add? I'm hoping you do. Add, because there's a form here for us to complete. The first question is, do committee members feel that they are assured by the information considered today? I see nods. I think it would be fair to say that we're assured by the information we've received that it's full and detailed. We're assured in general that management actions are being taken where they should be. Roger?
Just obviously we've highlighted the high risks, and so that in itself is saying we need to relate that. So we can't be assured that there's a bit of contradiction there. We can't be assured that everything's fine because we know that there's a high risk. But I don't know whether that's pertinent or not.
I think it's fair enough to say that we're assured that we have had full and detailed information, but perhaps concerned about the risks that we have identified. Fair comment? Neil, yes?
Yeah, I was just going to say, so just to sort of reframe that in a slightly different way, are you assured that the information you've given, that's been given to you, is from management information that management are managing as far as they can the risks that have been highlighted? So just to reframe that in a slightly different way.
Yeah, I think that's fair enough. That we're assured that the information is there, that management are taking action, but we'll also be wanting to hear that action has been successful. Yep, that's fair enough. The second question is, are there items that we think should be highlighted for the IJB? Any specific items, Gail?
Again, it's for the committees to decide what they would want to highlight, but just some suggestions in terms of listening to the discussions today. I think there was quite a lot of discussion around the two performance reports, the annual performance report and the other performance report, specifically on the whole system indicators of 4-hour access standard and delayed discharge. So you might want to highlight that's something that there was a number of questions around. In addition, the care home report, there was a lot of discussion on the fact that you wanted to recognise the good work of the staff involved. You might want to consider highlighting that to the IJB. And finally, around the last report you've heard, again, the assurance that the committee has sought around mandatory training, support for the provider care home, and the corporate approach around aggressive incidents. Again, you might want to consider those. Again, don't want to tell you what to do, but some suggestions you might want to consider to highlight to the IJB.
Yeah, it's useful for someone who's kind of been listening to it to pick out the things that seem to be relevant. Did you get all of that? Yeah, excellent. Does the committee agree that those are the things we should be highlighting? And I do think we need to say a very big thank you to the staff in terms of the care homes and make sure that that is properly recorded, that there has been such good work coming on. And I think we also need to recognise that there are concerns about some of the risks we've discussed. Any other things that we should be highlighting for the IJB? Are you satisfied, Jim? You've got enough there to enable you to fill that in for Gail and Marie. Right, thank you very much. With that then, I will say thank you all for your attendance and for your comments and questions. And have a good weekend when it comes. And let's hope the sunshine stays. Thank you very much.